Ladies and gentlemen, welcome to a new case in the ASAS Online Case Library. Today, we're presenting a case of a 62 years old male patient who came to us from neurosurgeons. The initial presentation in the neurosurgery happened because of back pain in cervical, in the thoracic spine, but mostly in the cervical spine. Because of this back pain, imaging was performed, and we can dive in immediately in a first set of MRI of the cervical spine.
So here we see the T1 weighted scan of the cervical spine, and we see that there is some signal abnormality in the 6th and 7th vertebral bodies. This is even more evident if we look at the scan after gadolinium injection. So this is a T1 weighted scan with fat saturation after gadolinium injection. So you see the fluid, the cerebrospinal fluid is dark. We see that the subcutaneous fat is dark, so it's suppressed. And we have this high signal intensity lesion in the 6th vertebral body and a little bit also in the 7th. And we can see that there are irregularities of the end plates of these vertebral bodies, and a little bit there's also like granulation tissue that we see here in the upper end plate of the C6 vertebral body. And a little bit also there is this low signal intensity lesion, which could be due to some fluid or even some abscess. And also what's very interesting is to see that there is some soft tissue lesion outside of the vertebral body. So that is something that would be suspicious for spondylodiscitis, for instance. And here you see the stir sequence in the coronal slice orientation where you can appreciate the bone marrow edema again, and also a little bit the involvement of the soft tissue surrounding these vertebral bodies.
So overall, indeed, a very scary presentation, but at the same time, CRP level was only slightly elevated at the initial presentation. There was no fever, but because of this appearance, highly suggestive of spondylodiscitis, surgery was performed. Our colleagues performed a discectomy, and they sent everything in a microbiological lab, but no germs, no potential bacteria, marker bacteria could be identified, which could have been associated with this event. In addition to this, the pain, especially in the thoracic spine, was persisting, and that was the reason why a few months later, a second image was performed, focusing on thoracic spine, and now you can see what happened there.
So in the thoracic spine, we have selected here the T1 weighted sagittal sequence, the T1 weighted sequence after gadolinium injection, also the stir sequence. So starting with the T1 weighted sequence, we can see that there's some scoliosis. So you see the spinal canal is visualized here in the middle of the image, but not in the lower and upper part. So that means there is some curvature of the spine. In total, the spinal canal looks good, but we can see that there are low signal intensity changes in some of the vertebral bodies over here, and there's high signal intensity here, which would be compatible with fatty lesions. So it is a T1 weighted scan. So that means if something is of low signal intensity, like here, it should be something like water content or inflammation. And if it's higher than the normal bone marrow, then usually you have a higher level of fat in that part of the vertebral body. Comparing it with the T1, weighted scan after gadolinium injection, you see that there's in fact very pronounced enhancement of the bone marrow of at least 6, if not 7, vertebral bodies of the thoracic spine. And we see this dark appearance here, which is due to the fatty transformation fatty component, which is not enhancing. And this is also good to show that that same lesions in the coronal slice orientation, and this is now a stir sequence. So that means that this is coming up due to the increased water content. So we see there is bone marrow edema in most of these vertebral bodies. You can see also the fluid in the nucleus pulposus, which is normal, and there's also some soft tissue component here outside of the vertebral bodies surrounding the costovertebral joints. Also, I see here there's a little bit of pleural effusion. So comparing the sequences in order to learn a bit about how MRI works, we can see here the comparison between T1 and T1 gadolinium. So you see the dark areas here, they are enhancing, and the fat is here suppressed, so it's dark. And comparing it with the stir, you see that stir is also a fat suppressed technique, so the fat is rather dark, and we have this high signal intensity changes here. Okay, what happened next, Denis?
Yeah, so with this massive bone marrow edema in the spine and no clear indicators of infection or of malignancy, the colleagues thought it might be an immune-mediated inflammation and referred the patient to a rheumatologist. At the rheumatological examination, we couldn't identify any signs of spondyloarthritis, meaning no peripheral involvement, no extramuscular skeletal manifestations, including absence of psoriasis. There was some limitation of the spinal mobility, especially in the thoracic spine, but that was it. So CRP was only slightly elevated, and H-Lab 27 was negative. The patient also brought an lumbar MRI where we could see also sacroiliac joints. So I'm curious what the judgment on sacroiliac joints would be.
Exactly. So we have this MRI scan performed some months later after the last thoracic MRI scan, and we see that is a T1 weighted sagittal sequence where we see again the vertebral bodies of the lumbar spine look fairly normal, except of the L5 S1 junction where there is disc height loss, so it might be some degeneration. Here we also see some osteophytes over here, and also we can appreciate the changes here in the lower thoracic spine, and we see there is some bony outgrowths and bony proliferations over here bridging these vertebral bodies and also leading to erosion, which is kind of a sign for an inflammatory arthropathy with osteoproliferative tendency. So then comparing that with the T2 weighted sequence that we can see here, we see that in fact there is high signal intensity still here, which we know already that it's due to bone edema. And also we can see that here there was some fatty change adjacent to the disc. And we now have here some brighter signal over here. So it might be also some edema in that vertebral body. And also it's possible to compare this to the coronal stir sequence where we see again these bone edema in the lower thoracic spine. But the advantage of this scan is that we can now also look at the sacroiliac joints, which is of interest for us. I'm trying to enlarge it a bit so we can see it nicely. So if we enlarge that, so we have it now here, and can go through the joint. It's not the perfect protocol of the sacroiliac joint as we recommended, but you can see there's no bone edema whatsoever, and also it's not looking like a lot of erosions. So there's negative the MRI scan is negative for sacroiliac joint involvement. So what was happening then? 1 year later, there was a next MRI scan. Dennis, do you know what was happening in between?
Yeah, so the symptom burden was not very high. The treatment was started with NSAIDs, but in fact symptoms were not completely gone, and that is why we decided to perform another MRI according to the appropriate protocol, also in order to decide whether treatment escalation is needed in this case.
And this is now a really nice MRI because we have a total spine imaging. So that means usually these kind of images, they are acquired in 2 or sometimes in 3 steps. So first the cervical spine, then we have the thoracic spine and the lumbar spine, and that is fused together with the post-processing workstation on the MRI scanner. And so you have these nice images showing the entire spine from the atlas till the sacrum. And we see there is now this new bone formation over here. I think I will shortly compare it to the initial change. And also we see this extensive bone marrow edema, which somehow persists. So it's 1 year in between, but still we have this extreme inflammation in the vertebral body and also involving the costovertebral joint. So it's going here into the costovertebral joint, into the pedicles. So it's also involving a bit of the facet joints. And looking here at the lower lumbar spine, we see some posterior edema lesions, but in the same time, the nucleus pulposus is dark, so there's loss of fluid inside the disc. So these two could well be some degeneration. Okay, so that is so I wanted to compare it. So let's take this first T1 that we had and compare it to the T1 that we have here. And I think the ossification was still there at the beginning. So maybe there was a bit more fatty content now, but the ossification did not so much progress or during this 1 year. It was already there at baseline.
So after this MRI showing persisting and very active inflammation in the spine, the diagnosis was made of axial spondyloarthritis. Sometimes we see similar pictures in psoriatic arthritis or in patients with SAPHO, but as you remember, there were no other signs compatible with SAPHO, or there was no psoriatic skin involvement. That is why we concluded the presence of HLA-B27 negative, rather atypical axial SPA, and escalated the treatment. The patient had a history of tuberculosis as a child. That is why in this case, the decision was made to go up to a biological DMARD from the IL-17 blocking group. The treatment was applied, was tolerated very well, and we have, in this case, also follow-up images after several months of treatment with an IL-17 inhibitor.
Shall we show these images? So this is a T1. Again, this is a total spine image, and you see now there is a lot more fat. We will compare it to the initial images as well. Also here we see the metal inside the vertebral bodies that was inserted by the neurosurgeon, and here we have the stir sequence of that patient, and it shows a rather impressive regression of the inflammatory changes. So these vertebral bodies are now almost normal. There's some residual inflammation over here, but in total, a very good result comparing the images before the treatment and after the treatment. That is really impressive to see what this drug has done and how the inflammation was switched off, and also comparing the T1 of the initial manifestation with the manifestation at the last follow-up. We can see that the all these vertebral bodies, they have now an increased fat content. So this is a transformation of the inflammation into a fatty lesion, which is a sign of healing and a sign of regression of the inflammatory activity. Very nice case. So what could we conclude of this case, Denis?
Yeah. So that was diagnostically definitely a challenging case because of an atypical presentation with late onset, with start with cervical thoracic pain, with those traumatic images at the beginning, suspicious of spondylodiscitis. So I think the initial steps were quite right to rule out an infection. But afterwards, I think we could have shortened the delay till rheumatological presentation and treatment. So we still need to do some educational efforts for our colleagues dealing with back pain patients when to suspect immune-mediated spondyloarthritis. And the presentation is, as we mentioned several times, not typical for spondyloarthritis. We see really massive inflammation in the spine, but nearly nothing in sacroiliac joints. How would you describe those changes, having seen spinal MRI for the first time?
I think this is really a case where the value of a musculoskeletal radiologist is showing up, because if you see this kind of inflammation in this thoracic spine, so usually the diagnosis of chronic non-bacterial osteomyelitis, CNO, which is the new nomenclature for the SAPHO syndrome, comes into mind. So there are some differential diagnoses, for instance, in TB-related spinal disease. You also have multisegmental inflammatory changes, but usually in those cases, we have also destruction of the end plates sooner or later, and also the abscess formation in the paraspinal soft tissues is much more pronounced. I have to say, looking at the initial images, there was no other option than to get some histology or some microbacterial workup, because this very much looks like a spondylodiscitis, also due to the soft tissue manifestation here. So it's very impressive to see that this was a sterile lesion. Maybe one should have done first a needle aspiration, and when that proves negative, to do further workup, maybe like a total body scintigraphy, or this additional MRI that was performed. I don't know how the pain was in the thoracic spine. Maybe he initially told about the pain in the thoracic spine in addition to the cervical spine, but neurosurgeons did not really appreciate these fully to do further workup. So that operation that was performed might have been not necessary at the end.
Yeah. Thank you very much. That was very reassuring. So we see another very nice example where multidisciplinary care was able to provide right solution for the patient, and luckily the right diagnosis was made and the appropriate treatment was applied. Thank you very much for listening and watching, and hope to see you soon.
Thanks for watching and enjoy learning with the ASAS Online Case Library, and we are soon back with another case. Bye-bye.